Thank you. I hope you can all hear me well. Thanks, Dr. Karthikesan and the whole panel, and thanks, Dr. Sendil Kumar, for this interesting introduction. Um, I will try to insert some calmness into this, and I just want to talk to you about a case that illustrates all the complexities of how you manage electrical storm. Um, So this is a 16-year-old kid from Alabama who I met in 2013, some early 2013. He was an ultra athlete. He ran about 50 marathons since the age of 11. In March 2013, he was swimming and had a cardiac arrest, sunk to the bottom of the pool. They pulled him out. They had an AED right next to there. One of the family physicians was swimming in the next lane, and he diagnosed VF and appropriately delivered therapy and resuscitated him. There was no obvious structural heart disease when they evaluated him locally. An ICD was implanted for secondary prevention. They thought it was possible long QT, although there was no family history of this. In May 2014, about a year and 2 months after the initial episode, he had what looked like polymorphic ventricular tachycardia while running and had a 36 joule ICD shock. And his ECG, he was referred to us for sudden cardiac death, inherited arrhythmias syndrome management. When I saw him, his ECG already showed precordial T-wave inversions in V1, V2, V3, and there was a lot of fractionation on the upstroke of the S wave. He was a young kid, an athlete with some mild RV dysfunction on echocardiography and all these T-wave inversions, and we diagnosed early right ventricular dysplasia, which is a rare genetic and inherited right ventricular myopathy with a high risk of sudden death. When he came, we also did RV endocardial and epicardial mapping. And because during epicardial mapping, I noted a lot of scar in the basal aspect of the right ventricle. Here's shown an epicardial map in the left top corner. And he had lots of areas of scar with multiple reentrant VTs induced from that circuit. So I ablated several VTs in this guy, and he was not inducible. Following catheter ablation, we discharged him on a beta blocker. Well, in November of 2013, again, he had 2 ICD shocks in a rock concert. He was there with his friends, and suddenly he had 2 ICD shocks, almost spaced by about 5 minutes. He was started on oral amiodarone in addition to beta blockers. In March, he had a cardiac arrest with the defibrillator in place after climbing 2 flights of stairs in college. At this time, he was 17. He had CPR for about 60 minutes. We started percutaneous hemodynamic support for PEA, and he was on a hypothermia protocol. This is just a part of his device interrogation. As you can see, there were multiple episodes of shocks delivered by the device, and a total of 150 shocks was received within a span of about 30 to 60 minutes. He was stabilized with anesthesia and was started on IV amiodarone. In the ER, they inserted an impeller for hemodynamic support. He had a repeat EP study, was flown to Hopkins from Alabama with 2 morphologies that VT induced. We performed extensive ablation, again, and another epicardial ablation. He had an EP study, 3 days as an inpatient, which showed no inducible VT. The guy made a miraculous recovery after all this. The exercise stress test showed no non-sustained VT. Again, this was after the ablation. And again, in July 2014, he had 4 shocks while chasing a dog. It was clear with the ICD interrogation, each shock would terminate the VT, but the VT would promptly restart again. Now, we were kind of at the end of the road on what else to do. So we took him to a different center, UPenn, to have a fresh pair of eyes to take a look at him, because at this point they were considering even heart transplantation. Although he had no signs of heart failure, he was still running, he was still an athlete, and the reason for possibly considering transplantation was only because of recurrent and refractory arrhythmias. At Penn, we had another attempt at catheter ablation. He waited to sustain VT as soon as he was entering the EP lab. He became anxious, and the next minute he was in VT. They were planning to cardio with him, so they administered deep sedation with propofol. It promptly terminated. We were able to induce fast VT on low-dose epinephrine infusion. We again performed extensive endocardial ablation, and after 7 hours of ablation, he was still inducible. So epicardial access was attempted but could not be made because he had too many adhesions from the 2 prior epicardial ablations. Well, they performed a surgical cryoablation. They opened up the chest and marked the areas that they needed to ablate on electron-atomic mapping and froze the entire basal half of his right ventricle. In September, 6 months after, he was back in VT. He had 6 shocks while running to catch a flight, and all of these shocks were spaced. He had 3 shocks, and then he had 10 more minutes, and after that, he had 3 more shocks after that. All were monomorphic VTs with variable cycle lengths with prompt reinitiation after each shock. So kind of at the end of the road. He's received several ablations at 2 probably high-volume centers. He had also an open chest cryoablation. He was still 17 years of age. Parents were making all the decisions on what needs to be done. There was a lot of frustration. So what else can we do? So this is not an uncommon situation, and this kind of falls into one of the definitions of electrical storm. Normally, if you think about electrical storm as one episode of continuous VTs, incessant, these usually are pre-death, meaning when usually a failing heart has incessant VT or patient with ischemia has incessant VT, then usually there's a very high mortality and death is imminent. But more often, we are posed with people having 3 or more shocks within a day, within a 24-hour period. And that's what an electrical storm is all about. It's not that they're in VT all the time. They have a device and develop 3 distinct episodes of VT during the day, and that qualifies for an electrical storm. It is not uncommon. It happens in about 10% of ICD recipients and comes in many different flavors. It could be recurrent fast VT, could be slow, incessant VT, many times seen in patients with ischemic cardiomyopathy, like what Dr. Harikrishna showed. Patients with inferior valve myocardial infarction can have slow, incessant VTs with a very large excitable gap. So easily they get into the VT, they stay in the VT, you shock them, or the device treats it. Sometimes the device tries to ATP it into a faster VT and then shocks it again. And then immediately, within an hour, they're back in slow, incessant VT. And it also can occur in the flavor of polymorphic VT, which is unsustained, like in patients with long QT syndrome, having multiple brief bursts of torsade. It can trigger the device or cause enough instability that you would end up shocking it, but immediately they're back in the VT again within several minutes later. It's especially common, as I mentioned, in ischemic cardiomyopathy, inherited channelopathies, like the sodium channel abnormalities, Brugada syndrome, like long QT syndrome, and also sometimes in inflammatory cardiomyopathies and sarcoidosis and sarcoid-related or other inflammatory diseases. It seems to be less common in familial dilated or idiopathic cardiomyopathy. It's not frequent to see patients with incessant VT in this condition. Whichever the condition is, it causes, it creates a situation which is associated with a very high mortality. Now, it's an elegant paper in 2013 which describes the acute management of electrical storm, and nothing much has changed as far as the basic steps are involved. The first thing is preserve life. You have to do ACLS and whatever measures that are required to maintain an airway and also a proper circulation. Sedation seems to be an important tool in management of VT storm or electrical storm. Now, based on the ECG morphology, how you treat slightly varies. If it's monomorphic VT, often in the setting of structural heart disease, amiodarone seems to be the drug of choice, and it goes all the way down to even considering VT ablation in the acute setting. In patients with polymorphic VT, often in the setting of prolonged QT syndrome, isoproterenol or overdrive pacing seems to be extremely useful, in addition to replacing electrolytes, which mainly becomes magnesium and potassium. Ischemia, again, is a common cause of refractory VT, which is slow and incessant. Inferior MI appears to be one of the most notorious things that causes a lot of refractory VT. Amiodarone and beta blockers are useful. Lidocaine can be useful. And of course, revascularization seems to be useful. And there are other rare causes for Brugada syndrome. Quinine as a drug seems to be very useful in addition to isoproterenol. I did go over this, and very specifically, we use amiodarone, ischemic VT, and lidocaine, a beta blocker, especially if they can tolerate this. We have performed several VT ablations in patients with incessant VT in the setting of ischemic cardiomyopathy. The only problem is that you need some sort of hemodynamic support to do this ischemic VT ablation. Patients with sarcoidosis, amiodarone and procainamide can be useful. Procainamide can be especially useful when they have lots of triggered VT because of inflammation. But one has to be careful about its depressant effects on LV function. Be careful to monitor the procainamide levels. The role of steroid is controversial, although many patients are treated with pulse steroids during episodes of acute inflammation and VT in sarcoidosis. In patients with right ventricular cardiomyopathy, especially RVC, beta blockers seems to be the drug of choice. Again, procainamide, amiodarone, and flecainide. Oral flecainide is also useful. Brugada syndrome especially responds to quinidine and long QT to isoproterenol. Patients with CPVT, another entity associated with refractory VT, is catecholaminergic polymorphic ventricular tachycardia, behaves very similar to ARVC and responds to beta blockers and flecainide. For refractory VT, what sort of hemodynamic support should we choose? Intra-aortic balloon pump is the easiest one to do, but often very ineffective. It may improve coronary perfusion, especially if you're thinking about revascularizing this person. You may want to use an IABP. Impella provides good support, especially the Impella, where the higher levels of Impella 4.05. But this is expensive and hard to justify the use in a low-resource setting. We do use ECMO frequently in patients with refractory VT, especially if they're young, have good left ventricular function or are salvageable. But you clearly need an exit strategy. You cannot be putting patients who have really bad systolic function and a grotty heart who are not transplant candidates on ECMO because there is no other way to go. And finally, cardiopulmonary bypass is very rarely used, but we have used in patients who develop refractory VT in the setting of cardiac surgery. Now, coming to other techniques of how you tackle patients with refractory VT, you have a whole host of things. Sympathetic drive seems to be very important. As I suggested earlier in our patient, sedation was the one important thing that worked every single time, especially in the setting of anxiety and exertion. That's what actually provoked his ventricular arrhythmias. Now, you have two options: decreasing sympathetic drive or increasing the parasympathetic drive, although this seems to be less effective in the acute setting. The decrease in sympathetic drive can be done by thoracic epidural analgesia, a stellar ganglion block, or sympathetic denervation, and finally, renal denervation. The stellar ganglion block seems to be the easiest one to perform, although it does require some degree of coordination with people who know how to do this in an outpatient setting or in an acute setting. This block is performed right at the level of the C7 vertebra, and the injection causes Horner syndrome, and that's how you know you have blocked the stellar ganglia. Now, this is an elegant study in 2019 showing significant reduction in VT episodes, arrhythmia episodes, and defibrillation shocks before and after stellar ganglion block. Shiv Kumar's group has published on the value of thoracic epidural analgesia, where they deliver 0.25% bupivacaine and T1, T2 interspace. It even allows patients to be ambulant after doing this with an epidural catheter, and has a great success report of terminating and also reducing electrical storm episodes. Here's a case and illustration from their Heart Rhythm paper in 2005, where they show amiodarone intubation and institution of TEA and significant reduction in arrhythmia in a patient who had multiple shocks during this hospital course. They also showed that these patients subsequently do well with bilateral cardiac sympathetic denervation. The same patients who underwent TEA also seem to respond to bilateral cardiac sympathetic denervation, suggesting the role of sympathetic nervous system in initiation and maintenance of these arrhythmias. Finally, renal denervation has been done to reduce VT episodes in select patients by select groups, although it's not something that's widely performed in the setting of an electrical storm. Some centers have resorted to this in patients who fail cardiac sympathetic denervation as well. Now, renal denervation for VT storm seems to act by several different mechanisms, although decreased sympathetic norepinephrine spillover from the renal blood vessels, and also another decreased sympathetic mediated calcium signaling and decreasing repolarization heterogeneity at the scar borders have been proposed as possible mechanisms. How did my patient do? This is the same patient that I talked to you about. This patient underwent bilateral sympathectomy, and this was performed in November of 2014 in UCLA. This was one of those patients who actually was flown over to UCLA to perform the sympathectomy. This was prior to our center starting our own sympathectomy program. His ICD discharges in the 6 months prior was over 80, and post-sympathectomy, he still continues to do well. Almost 8 years after his sympathectomy, he has had no recurrence of VT. He's gone through college, and now he holds a full-time job. Still has some fair bit of RV dysfunction, probably some from the ablation and the cryoablation, but significantly much better from his VT standpoint. So I want to summarize with, for electrical storm, think about how the first thing you do is to intubate, sedate, and establish general anesthesia. This is how you get control. You need to also focus on how do you maintain hemodynamic stability and use the appropriate one based on your local practices. But in general, ECMO seems to be the easiest one to do. It's less expensive and also most effective, but have an exit strategy. IV amiodarone seems to be the drug of choice in most cases. You can choose the antiarrhythmic drug based on the substrate. Acute neuraxial modulation requires some degree of coordination between the person who does the stellar ganglion block, would be an anesthesiologist, be a pain management specialist, but you need some degree of coordination. It's even something difficult that even we're working at our center on how to make it happen, but we have done it on special cases where an anesthesiologist comes and performs the stellar ganglion block in CCU when the patient has a fracture VT. Use hemodynamic support early. In ischemic VT, catheter ablation really works, or even in any monomorphic VT, but you need to plan for it. How do you make sure that the patient does not get worse during the procedure? Always monitor gases, monitor renal function. These are the things that can go wrong, and even though the VT is successful, you lose the patient later on to something else. Consider revascularization wherever appropriate. Renal denervation is a possibility. And finally, sympathectomy seems to be a long-term procedure that helps to reduce arrhythmic burden in these patients. Thank you very much. And these are all our groups in the Cardiac Arrhythmia Center for Complex VT Ablation. We have Hugh Calkins, who leads the program. We have a thoracic surgeon on board, and we also have a bunch of people from UCLA who support our program. Thank you.